So this video will demonstrate an RSI assistant OSCE. For the purpose of the assessment, I am an ILS officer and my offsider is EMT. So today, what have we been called to?
We've been called to a 40-year-old male who's fallen 6 metres from a roof onto a concrete driveway.
Okay, so en route I'm thinking of some differential diagnosis. So was it a mechanical fall? Did he slip? Or was it something medical like a cardiac event, a diabetic emergency, a syncope, a stroke, or maybe even a seizure? So in this assessment, we would use the setup mnemonic. However, for this scene, the scene is safe. So I'm looking at the patient and what do I see?
You find the patient lying supine. He appears to be posturing and extending, restless and combative, moaning, breath holding and grunting.
Okay, so the main focus is obviously always ABCs to begin with. So for my airway, what do I see?
You find the patient is grunting.
Okay, so I'm going to reposition into the sniffing position. And does this help the grunting?
It does a bit, yeah.
Okay, and is this self-maintained?
It is.
Okay, for the breaths, what is the rest rate?
So you get a rest rate of 12, but it's irregular.
Okay, and is there any accessory muscle use?
No.
Okay, so I'm also going to auscultate the lungs. What do I hear?
Lung sounds are clear in all fields.
Okay. Perfect. And then for my circulation, what does the patient look like?
So the patient is pale with a peripheral cap refill time of 3 seconds.
Okay, so while I also ascertain the GCS, my offsider will get a full set of vitals. So for a response to eyes, what do I get?
So the patient responds to pain.
Okay, so that's a 2. For a verbal response, what do I get?
He's just moaning and grunting.
Okay, so that's also another 2. And then for a motor response, what do I get?
The patient is extending.
So that's decerebrate, so that's also another 2. So he's a total GCS of 6. So also with a total GCS of 6 and a irregular rest rate of 12, he is an indication for RSI. So for this patient is time critical. We need to very stabilise and assess his vital signs constantly. So what's that full set comeback is?
So it comes back as a heart rate of 50, a blood pressure of 160 on 90, a rest rate of 12 but irregular, a BGL of 7.6 and a temperature of 37.
Okay, so this comes in line with Cushing's triad, and what's the secondary survey comeback as?
Secondary survey comes back as a isolated injury to the occiput with an obvious boggy patch about 6 centimetres in diameter.
Okay, so this patient is a TBI patient, so we will also call for R50 backup for RSI. So 81 to call?
81, go ahead.
Can we please get R50 for RSI? We've got a status 1 TBI patient, GCS 6.
Copy that, 10 minutes away.
Cool, thank you. So we are now in the back of the ambulance where it's a controlled environment, and we've got much better lighting for the RSI officer when he arrives. So before RSI, we need to manage this TBI of this patient. So we've removed the hard collar and we've placed a soft collar by placing 2 towels rolled up on either side of the patient's head. We've also put the patient into the sniffing position by rolling up a towel and placing it underneath the patient's head. We're maintaining an airway at this moment with an OPA which has been currently tolerated by this patient, and we've also got supplementary oxygen flowing through nasal prongs for this patient. We've got the monitor attached by the NABP, the ECG 12 lead, as well as SpO2. And this is going to be set on the monitor to monitor the vital signs every 5 minutes. We've got large bore IV access in both ACFs of the patient's arms. In one ACF, we've got a primed line of sodium chloride, which my offsider has drug checked. However, it is not currently running as the blood pressure has not dropped below 120 systolic. If this does occur, we will titrate to effect. We have also got some morphine drawn up. So this is a 10 mg and 1 ml IV with 9 ml of sodium chloride solution together. So my offsider has drug checked both of these drugs for me, and this will just be sitting here for when we need to use it. We will also start with a 3 mg dose to begin with to fight any analgesia and any combativeness the patient may have. We will also see the response the patient has with their blood pressure from this morphine, and if the response is good, then we can provide more. Now that we've managed this patient's TBI, we can now prep for RSI. So my offsider and I will verbally check with the checklist for everything we need for RSI. So
attached nasal prongs.
Yep, so we've attached nasal prongs with supplementary oxygen flowing.
Pre-oxygenate using a reservoir mask at 10 litres per minute.
So we don't have a reservoir mask, but we've got a BVM that I can just hold over the patient and then we can supplement them that way.
Attach monitor with ECG, NIBP and SpO2.
Which we have all done along here, which will be monitored every 5 minutes.
Prepare ETCO2 if this is available.
So we've got this now attached to our BVM mask.
Position the monitor so that it can be seen, leaving space to the right of the patient's head for intubation roll.
So we've got the monitor facing me. I'm placed in the dicky seat. It is on the second stretcher provided in the ambulance. It is facing so that my offsider can also see it, and also the RSI officer can see it when he arrives.
Gain IV access in 2 sites, preferably.
So we've got 2 16 gauges in the ACFs of both arms for this patient.
Prepare a running line of 0.9 sodium chloride.
So we have it prepared but not currently running.
Place a folded towel under the head.
Yep, we've got the patient in the sniffing position at this moment.
Place an ETT holder with a strap under the head.
So we've got this strap here and ready.
Ensure suction is working and place the rigid sucker under the towel.
So we've got the rigid sucker under the towel currently, and the suction is working.
Prepare a manual ventilation bag with a PEEP valve attached.
So we've got our BVM here, and we've got the PEEP set at 5 centimetres of water.
Obtain a set of vital signs.
Yep, so we've got our monitor to set vital signs at every 5 minutes.
And prepare the area.
Okay, so we've got to prepare the area. We need to get off anything that we don't need at this moment. So that's any rubbish, any gear that we're not going to use during this RSI procedure. I can get my offsider to do those things for me. And we've got this space here to the right of me for the RSI roll and everything. Also, before the arrival of the RSI officer, is that an ILS officer should know the failed intubation drill, as well as the burp maneuver. So that is the backwards, upwards, rightwards pressure of the trachea, which will help the aid of the visualization for this RSI officer in the aid of the intubation, as well as a bougie, which will keep the ETT tube rigid during the intubation process, as well as a cricothyrotomy, which is a last resort for this patient if intubation were to fail. As well as we've got all our resus gear ready, like our BVM, we've got the pads attached, and we've got all our other gear ready if resus is required. So the purpose of this video is to show synchronized cardioversion, and I'll be an ILS officer and my offsider will be an EMT. So what have we been called to today?
A 70-year-old male for chest pain and collapse.
Okay. So on the way to this job, obviously we want to consider safety, so we'll use the setup mnemonic. However, for the purpose of this assessment, we would just be saying that the scene is safe. So on arrival, is there any family there at all?
No.
No. So on examination, the endobetogram, he's obviously seated and is lazy boy. He looks quite pale. He looks diaphoretic, and there looks like there to be a slight increased work of breathing. So I'm going to introduce ourselves. Hi, my name's Louise and this is Gemma. What's your name?
Bob.
Bob? Okay, Bob, I'm just going to have a feel of your wrist. What seems to be the problem today?
Oh, I've got really, really bad chest pain. Like my heart's just like pounding, like right up into my neck, and it feels like it's trying to like jump out.
Oh, okay.
Yeah, it's just really painful.
I can't get a radial pulse, so I'll move up to this brachial. Okay, there seems to be a weak brachial pulse and a strong carotid. Cool. So when did this come on?
Oh, I don't know. I'm a bit confused. Maybe 15 minutes ago, 10 minutes ago?
15 minutes ago? Okay. And is there anything that makes it better or worse?
No, it's just really bad and I'm just not feeling very well.
Okay. And you were saying, does it just radiate up into your jaw?
Yeah.
Okay, and it feels like your heart's about to come out of your chest?
Yeah, it's really, really sore.
Okay. And 10 being the worst pain in the world and 0 being none at all, what are you feeling?
Oh, it is definitely a 10.
Definitely a 10? Okay. So, how are those vitals going?
Just printing my ECG now.
Perfect. Oh, yes, thank
So
you.
he's got a peripheral cap read for the time of 4 seconds.
4 seconds?
His blood pressure is 70 on 40.
Yep.
He's got a wrist rate of 18.
Mm-hmm.
A BGL of 7.6. A temperature of 37. And a SpO2 of 88.
Oh, perfect, thank you. So I'm just going to have a listen of your lungs, Bob. Is that okay?
Yeah.
Yeah, so...
My head feels a bit funny too.
Cool, so there's bilateral crackles in the lower lobes. If you can please get some nasal prongs ready for that O2. Has this ever happened to you before, Bob?
Oh, not like this. No, I hadn't. I think it's called an MI about 5 years ago.
Oh,
But
okay.
I wasn't feeling as bad as this. It was totally different.
It was different then?
Yeah.
Okay. So what I'm saying is some YQRS complexes, no P waves, and it is regular. So I'm seeing VT. Is that what you see here as well?
Looks like VT to me as well.
Are you on any medications, Bob?
That blood thinner, aspirin and Cilazapril.
Oh, okay. And what I want to do is we'll get a 12 lead going, and if you can also get the pads on.
Yeah.
Cool.
I've got a 12 lead attached. I'll just punch it out for you.
Perfect.
I'm feeling a bit dizzy as well.
Oh, real dizzy, okay?
Mm.
Cool. Sweet. So it's definitely confirming VT, and the best airways are in V2. And so Bob, what we want to do is your heart's beating a little bit too fast, so we kind of want to like electrically fix that. Is that okay?
Is it gonna hurt?
Yeah, it will hurt, but I will give you some pain relief to help that, and it won't hurt then.
And that should stop the chest pain?
Yeah, that will
Okay.
definitely stop chest pain. Cool. So if you can please draw up the fentanyl, and I will start get an IV line in. Perfect, thank you. So for the purpose of the assessment, an IV line has already been put into his arm. And is there any drugs lying around anywhere?
Nope.
Have you had any alcohol today, Bob?
Not this time of day.
No? Okay. And while Gemma is drawing up that fentanyl, I'll also get her to drug check, please.
So I've got fentanyl, 100 micrograms in 2 mils, expires 9:20. And sodium chloride, 10 mils, expires 10:20.
Perfect, yeah. So that is, fentanyl, 100 micrograms in 2 mil, 9:20. And sodium chloride expires 10:20. 10 mil.
Thank you.
Thank you. So Bob, are you allergic to anything?
No.
Okay. So also, while Gemma is also drawing up that fentanyl, I believe that Bob's level of compromise is at moderate due to his GCS being decreased because he only opens up to his eyes to voice. He is slightly confused, and however his motor response is good. Hey Bob, can you squeeze my hand for me please?
Yep.
Cool. So his GCS is 13. He also has hypotension. He's got myocardial ischemia as well as some shortness of breath. So that concludes his moderately compromised. And then so Bob, so you're not allergic to fentanyl?
No.
Okay, so what I'm going to do is I'm going to give you some pain relief, and you're probably going to want some, aren't you?
Yeah, I'm really sore.
Okay, so I'll start off first with 30 micrograms, and then we'll see how he reacts to that. And so cool, so that was 30, and then a flush. So to reassess ABCs, if I can please get another full set of vitals. His airway is patent. He is still talking to me. His breathing is still, his work of breathing is still increased. He does still have those crackles, as well as the SpO2 does seem to have increased when I look at the monitor due to the supplementary oxygen through the nasal prongs.
Blood pressure is still the same, 70 on 40.
Okay, thank you. Some differentials, I mean, they're can't exclude, but I don't believe that it's an electrolyte imbalance. We can't exclude hyperkalemia due to the ECG changes from a tachyarrhythmia. We can't exclude it. There is not really any toxins around or any like serious medications, digoxin or anything to indicate that it is a toxin effect or anything like that. He has had a previous MI, however, so it might be a reentrant tachycardia. Cool, thank you. So how is that pain going now, Bob?
Oh, it's still really sore.
Still really sore, so I'll give him some more fentanyl. And cool, so Gemma's just setting up for a resus potentially, just in worst case scenario. So I'm going to give him another 50 micrograms of fentanyl. And that flush. We'll also start lying him supine. So what we want to do now, Bob, not all the way, just about there, and raise his legs.
So he's actually at 98 now. Heart rate's still 170.
Okay. So Bob, what we want to do is we want to just electrically give your heart a shock. Is that pain gone down?
Oh, maybe a little bit. It's still sore though.
Okay. Yeah, so what I can do, I can give you a little bit more fentanyl, but yeah, we want to like just electrically shock your heart in the hopes that it'll come back into a normal rhythm. Does that sound good?
Yeah, that sounds good.
If Gemma, if you could please pull out the cardioversion checklist and verbally go through that with me.
So place pads in either the anterior, posterior or apex sternum position.
Yep, done so.
Ensure the defibrillator is in manual mode.
Yep, it's in manual mode.
Select the limb lead with the highest R wave.
Cool, so we've got V2 seems to be going at the highest, so we've connected it to that.
Minimise artifact by ensuring adequate lead placement.
Yep, so he's lying quite still, but there is no electric blankets around or anything like that.
Select synchronized mode.
Yep, so we're syncing.
Confirm there is a detection symbol above every QRS complex.
Yep, so I'm printing that out. Cool, so there's a little triangle above all the QRS complexes.
So, ensure the patient has received adequate sedation if indicated.
So is that pain still decreasing or?
Yeah.
Yeah, cool.
Select the joules, charge the defibrillator and confirm everybody is clear.
Cool, so we're going to maximum joules, all clear, just charging. And now all clear, shocking, cool. Now just assessing whether or not it's gone into normal rhythm, I'll give him it a print. If you can please get another full set of obs, and then we'll see to go from there. Once you've done that, if you can get a running line going.
Yeah. Just push that BP. Great.
Cool, so his 3 leads shows that he is in now normal sinus rhythm with a rate of 80. Yeah, so Reese's airway breathing circulation, his airway is still patent, is still clear. His work of breathing is still there, however it seems like it's less. Crackles will still be there, however we can revert that on the way en route to hospital. We'll also start driving towards our backup. His circulation, his colour is coming back. I've got a radial pulse now, and he is no longer short of breath. However, if he did not revert, we would be able to shock once more, because there's a maximum of 2 times that you can shock them. Otherwise, we would also seriously need to head in the direction of our backup so that the ICP can chemically revert.